Good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec. I'm the Managing Director for the Journal of Community Nursing. First and foremost, thank you very much for giving up your wonderful time on a Monday evening. And thank you to URGO Medical, who are sponsoring this evening. The session is titled Nice Guidance for Wound Healing, Translated into Real Life. And I'm very pleased to announce that I'm joined this evening by Tickle, who's a Tissue Viability Nurse Consultant.
Hi,
Joy,
Alec.
how are you doing?
Good evening. Yeah, I'm fine. It's actually nice to be face-to-face and in person, isn't it?
It's amazing.
It's quite scary, though.
A little bit scary. A little bit.
But nice to be here live.
Absolutely. So for those of you who have joined us before, you'll notice that over the last year or two, we've actually been recording these from our homes. So tonight is the first time that we've done an in-person recording in quite some time. So it's a very exciting time for us. So we hope you do enjoy the evening. As usual, certificates will be available at the end. There'll be links available from my team that you'll be able to copy to download your certificates for your revalidation folders. Please do ask as many questions as you possibly can through the chat function. We use those then to come back after Joy's presentation to host a live Q&A. I think that's about it for me, so I'm going to leave you to it to do the presentation, and I'll be back after that, after looking at all of the questions to do the live Q&A. So Joy,
brilliant.
Good luck, and I'll see you very shortly.
Great. Thank you, Alec. And good evening, everyone. And I'd like to reiterate what Alec said. Thank you for giving up your precious time to join us this evening. It's just a great pleasure to be sharing not just my clinical experience, but my colleagues' clinical experience in implementing NICE guidance for wound healing into practice and share with you how that translated into real-life positive outcomes for our patients. So we'll begin with the learning objectives of this evening, which are: what is evidence-based treatment? What does it mean? What is the need for it? How evidence-based treatments can be implemented, in lots of different organisations and different care settings. And open up a discussion with you about, can you implement evidence-based practice? Yes, you can. How simple is it? And yes, you already are. So enter into that discussion, and I think that'll come out a lot more in the Q&A session at the end with Alec. Now, we know evidence into practice is not a new concept. It's so essential for all clinicians that we keep abreast of evidence, recommendations pertaining to our particular practice. And that is not new, and it is so important. Evidence-based practice or treatments can be based around, we have NICE guidance, which are developed by independent committees that focus on providing us with evidence-based recommendations. And we have lots of NICE guidance available freely to us. We have research and evidence from RCTs and other studies available to us. And we have really good recommendations and evidence from National Wound Care Strategy Programme, Legs Matter campaign. So lots of really good evidence-based recommendations out there, around about not just wound healing, but reducing unwarranted variations in treatments and returning our patients to healing. So within my previous organisation and my current organisation, we did recognise that we did need to make some changes, and we needed to look at consistency really as well between different care settings. What we did notice is nationally that has been identified, there were inconsistencies and variations in assessment, in diagnosis and treatment. Now, if we have a delay in assessment and true diagnosis of a wound, then there are delays in the appropriate treatment or evidence-based treatment for that patient. And that's when we start to see that high prevalence of chronic wounds. Our organisation, being like others, we have a high prevalence of chronic wounds such as leg ulcers, diabetic foot ulcers and pressure ulcers. What we also found that we don't always record the clinical outcomes. So if we're not recording patient-reported outcomes or clinical outcomes, how do we know how effective our treatments are? How do we know what proportion of wounds we're healing, or not, as the case may be? How do we know where we need to make changes? And there was evidence of underuse of clinical evidence as well. We identified that. And I'm sure that you can all agree that COVID-19 added to those challenges that we've already just discussed with you and added enormously to our workload pressures. We required to support our clinicians during COVID-19 by changing the ways we delivered services, the way we trained staff in delivering those services. So I'm sure quite a lot of you were redeployed into services that you'd never worked in before, wound care being one of them. And I was involved in having to train clinicians very quickly, school nurses, health visitors, in wound care, because they were going to support the community nurses or clinics to deliver wound care. So enormous pressure. So we had to make sure that we were delivering that evidence-based training for our clinicians as well. Staff did report, and I totally agreed with them at the time, there was a lack of time to carry out those assessments, those ABPIs, those diagnoses, which made a delay in appropriate treatments. Of course, overall, that would mean high cost to your organisations, to the NHS. And I don't just mean cost of consumables or inappropriate treatments, but cost for your time. Your clinical time is so valuable, and cost then overall. But to me, the highest cost overall is that cost to that patient living with that chronic wound for months, even years, and the high cost to their quality of life and their families as well. So what did we need to do? What did we need to achieve? We needed to change, and we need to ensure that evidence-based care is totally embedded into our practice. So we wanted to ensure overall, as you can see on the screen, that timely holistic assessment, that accurate diagnosis, implementation of appropriate treatments. But what we also wanted to do was reduce those unwarranted variations in care. So that swapping and changing of treatment regimes with no clear rationale, no clear objectives. And that did happen. Very frequently patients would report to clinicians that on Monday they had that dressing applied, but on Thursday, seeing a different clinician, they had a different dressing applied. Why was that? Why had we got those unwarranted variations in care? And I'm going to share with you ways that we can avoid that as well. We wanted to, of course, improve and capture those clinical outcomes, and not just the clinical outcomes such as wound healing, reduction in exudate, improve patient comfort, but the improvement to the patient's quality of life. And we wanted to assist with adherence to really simple clinical pathways. And what those pathways is the research and the evidence embedded simply into a pathway. And we wanted to facilitate that implementation across organisations and all care settings. But what we found also with that is the simpler the clinical pathways, that can also support your patients in following them, or your patients' carers, and help to support that shared care or that supported shared care. And most importantly, what we wanted to achieve is to return the patient to healing. So I'm going to explain to you this evening, hopefully quite clearly, about how what we implemented achieved previously in a previous organisation, but then how we implemented the same evidence-based treatments and pathways into a new organisation, and how we transferred and replicated the really fantastic clinical outcomes. And I'm going to share that with you this evening. And I'm going to discuss the process of how we did that by implementing the pathways, by obtaining data, looking at the clinical outcomes achieved within the organisation, currently and previously. And then how that demonstrated that where you can standardise practice to achieve good clinical outcomes and reduce unwanted variation, regardless of the care setting, regardless of the organisation itself. So previous experience, excuse the pun, is nice to have. And I'm a huge believer that we can learn so much from each other and by sharing good practice. I don't believe we should work in silos. What good practice we should be shouting about, sharing. And, because we have loads of time restraints, and to me as clinicians, we ultimately want the best for our patients. So we don't have to start from scratch. We have the evidence there. I have the confidence from my previous experience about embedding best practice and nice guidance into practice, gave me the confidence to implement that and transfer that into different organisations as well. So what did we put in place? As I keep saying and will keep reiterating, we implemented a clear and simple referral pathway. And I'm going to share the next screen with you in a minute to show an example of that referral pathway. We implemented an evidence-based treatment plan as well that included the URGO Start treatment range. We introduced a wound care specific database, or what we called it was the clinical wound tracker. So we captured data about not just the patient's wound progression, but also their quality of life improvements, or not, as the case may be. We have provided appropriate staff training and mentorship to embed those referral pathways, to embed that data, capture that wound tracker as well. And of course, we've provided support to our patient carers and family members, because they would equally be responsible or take responsibility or ownership or part ownership or support of their wounds as well. So we really had to make sure we put in place a really good support network and training for our patients, their carers and their families. And you can see on the screen that referral pathway, and it is so essential to have a clear, simple and consistent referral pathway. Because what that means is you get timely referrals to the appropriate clinician or team in the right manner. And some of the patients that I've seen recently and in the past have had a wound for over 12 months, 18 months. Having a really clear, succinct referral pathway can prevent those delays and appropriate referral on, which means the patient's getting the right treatment, and it can be implemented from, as I said, from day one, from initial referral in. And it also can help to prevent inappropriate referrals that can be very time consuming as well, when you're having to manage to look through and triage that inappropriate referral. And as you can see on the screen, again, by implementing those evidence-based, simple, clear and transferable treatment pathways, it can ensure that we're getting the right treatment selection for the patient at the right time. And there's evidence of that treatment pathway on your screen. The simpler the pathways and the referral process means that it can be used across a whole array of different care settings, where staff have different knowledge, different skills, and different levels of experience. And that is important, isn't it? Where I'm working, we cover acute, community, nursing homes, district nursing teams, practice nurses. It has to be transferable and adaptable into those different teams. The clinical wound tracker, I thought this was a real importance of capturing data, but you've got to capture the right data. It's got to be relevant for you and your service and what you're trying to capture. It's got to mean something. Now, data capture to me, as a lead TVN, was difficult to try and produce a tool to help me with this because of time restraints and pressures. And also, I'm a clinician through and through, and it wasn't really an area of my expertise. But with the support and expertise from industry, and URGO supported me with this, helped me to produce a relevant and real-life data capture tool. And what we capture is what you can see on your screen, from existing comorbidities, duration of the wounds, wound treatments, wound size and depth, and quality of life score. Any data, it's got to be relevant that it can actually improve practice or change practice as well. So what results did we see? All of our patients healed within 16 weeks, 100% of the patients. 52% healed within 6 weeks and 97% healed within 12 weeks. Now, what I want to add there is some of those patients had their wounds for many months, even years. Okay, they'd had multiple variations in treatments and poor outcomes. And so the cost there is to the patient, but the high cost to the organisations and your clinicians' time as well. The wounds rapidly reduced in size. You can see that 45% reduced in size and wound surface area between week 2 and week 4. And between week 4 and week 6, 57% of those wounds reduced in average wound surface area as well. What was really interesting to me when we were capturing the demographics of our patients, that all of the patients had one or more existing comorbidities. And as you can see, some of those comorbidities were like diabetes, hypertension, other factors, but factors that can impede or slow down the wound healing process. So these patients were actually already high risk and had comorbidities that meant that it could slow down their healing process as well. They may be on or were on multiple medications to support their and manage their comorbidities, but again, certain medications that could influence the wound healing process and slow that down. So to me, that was very interesting that we still got these results when the patients had a multiple, one or more range of comorbidities. We also saw those positive results across a range of other criteria. Now that is from the pain scores, the patient comfort increased, pain scores reduced and was improved, from exudate volume to surrounding pain. And to me, you know, this is not just a reflection of what we put into practice. If you look at literature where there's good standardised practice and good care, you know, these results will also be achieved as well. And if you improve pain and exudate volume surrounding skin, you are going to improve the patient's quality of life. So what did it mean in clinical practice, though? What did it mean overall? Well, it was that standardised approach to care with those reduced variations in practice. I mean, those patients and the patients we're in my new organisation where we've implemented this is we are seeing less reductions in variations care. We have a clear pathway, the clinician has a clear pathway, and the patient totally understands what their treatment pathway looks like. And why shouldn't they? It's their wound. Increased staff confidence. So staff reported and reporting to me now, they feel more confident because they know it's evidence, they know it's current evidence and it's embedded into the pathways, but they have confidence to follow it because of that. Because it's simple, they also know that they can transfer that across their teams or skill sets, you know, where somebody may be newly qualified or have less experience in wound care. And they also said it helped to support their accountability. And let's be honest, accountability is so important. We need to protect ourselves. Ease of use, not just for staff though, patients that were involved in supported shared care, again, they could understand their treatment pathway. They understood what needed to be implemented and understood whoever was carrying out that wound care, they understood what to do as well. And what quite a few people reported, and I myself find that when you're talking about a simple pathway or a treatment plan for a patient or treatment pathway, you are opening up a whole new dialogue with them, which is what we should be doing because it's empowering the patients to take ownership of their wound. And that's what these pathways did. It made us open up that dialogue, engage with the patient more, be more confident engaging with that patient, and set joint objectives with the patients about their overall treatment and about their overall goals of healing. To the organisation, you know, we always want good, effective clinical outcomes, but we also have to ensure cost-effective treatments as well. And, you know, potential savings have already, as you can see on your screen, have already been identified by NICE. You know, that work's already been done. But what we want to do is ensure cost-effective treatments, reduced unwarranted variations, which again is additional cost, improve wound healing outcomes, free up time and reduce associated costs also. So the evidence, the clinical data and the excellent outcomes from our past success just gave me the added confidence that, you know, why don't I transfer that into other organisations and my new organisation where I'm working and replicate the practice and achieve the same fantastic results which we are doing. So what I'm trying to say there is it was so easy to transfer and replicate that evidence-based practice into another organisation. So I went from Shropshire to the Isle of Wight. And, you know, it's quite a journey that. It's quite a far journey, isn't it? But, yeah, that's where I went. So I'm going to finish this evening by sharing with you 2 case studies about returning our patients to healing. But what it's about is by embedding that clinical evidence and that experience and the pathways, what it meant to our patients, what it meant about returning our patients to healing. So this lady was 71. She has had a wound for 4 years plus duration, causing a severe, not just pain, but poor quality of life, impacting on her quality of life. She's had multiple variations in treatments, multiple courses of oral antibiotic therapies over the period of time, with very little successful outcomes. She has rheumatoid arthritis, which we know the small vessel disease can impact wound healing, particularly on wounds on the limb. And she was on various medications that, again, can affect the wound healing process. She's retired, but she's a grandmother, she's a wife, and she wants to be as independent as possible. Her quality of life score was high. This was really impacting on sociability of being able to leave the house, the pain, just looking at that wound on your screen, you can imagine the amount of exudate that wound would produce, frequent infections. A pain score, 10 being the highest, was 8, so causing a significant pain. She was on regular analgesia, but again, that was causing her problems. She didn't like to take the analgesia regularly because it had other effects on her health as well. So what we did is, from day one, appropriate referral, and you might say there, well, okay, Joy, that lady, 4-year history, why wasn't she referred? Why wasn't she referred sooner? And what I will say is because there wasn't a referral process in place. There wasn't a robust, simple referral pathway. So it wasn't the clinician's fault who was caring for that patient. There was no signposting of how to do that timely and appropriate referral. And when it was implemented, guess what? That clinician, rightfully so, referred that patient immediately to tissue viability. So we continued the cleansing and debridement with wound bed preparation that we'd always continued. We implemented the URGO Start Plus primary dressing because we wanted to re-energise the wound healing. We wanted to kickstart that wound healing process. The lady was already receiving URGO K2 reduced compression therapy, and we continued that as well. And I'm going to share some pictures with you. And we continued that for 16 weeks. So can you see the improvement that you can see? In 16 weeks, the wound had dramatically decreased in size. The quality of life patient score had dramatically improved, okay? And at 20 weeks, it completely healed. But at 16 weeks, when the wound was smaller and the exudate was low to moderate, we started to talk to this lady about supported self-care. Now, this lady had significant rheumatoid arthritis to her hands, her feet. Her dexterity in her hands was poor. But just because she couldn't physically manage the wound didn't mean that by discussing with her, is there a family member that you would like to get involved in managing your wound? And it was. She had a family member who would happily help her mum to manage the wound. So she was then put into compression hosiery class 1. Okay, so we continued the reduced compression, but we gave her the option for supported self-care. She continued to see the clinician as well to support that, but in between, the patient's wound and skin care and everything else was cared for by her family. By week 20, the wound had completely healed. Now, I don't think you need me to harp on too much about the positive outcomes for her quality of life. The impact, she was elated. She knows the risk with having small vessel disease and rheumatoid arthritis, that some of her fear was losing the limb as well. But you can imagine the clear positive outcomes for that patient. And our final patient is a 93-year-old gentleman. He's got diabetes, and he had this diabetic ulcer to his toe for 4 weeks in duration. He's got, as I said, diabetes, he's had rectal cancer and B12 anemia, so he's got comorbidities there that could influence and impede his wound healing and put him at high risk of infections and sepsis. And he had recurrent infection over that 4-week period as well. Now, we may say quality of life is only affected negatively by the larger the wound or the chronic wound. But I will say to you now, quality of life is quite subjective. It's very subjective and personal to the patient. This patient only had the wound for 4 weeks. It was a new, if you want to say new wound, but it was it's a small wound. But it still impacted negatively on his quality of life. He lived in a residential care home, and, you may say, oh, well, maybe he can't get out much, or it wouldn't infect him too much with his quality of life. This gentleman was too embarrassed to go into the day room. He was worried that he would catch or knock the toe and cause significant pain. Sometimes there was malodour, there was odour there, and that caused him distress. So it did impact his quality of life. At night, it was more painful because of the bedclothes, and obviously the care staff did look at use of aids to help with that, but it was significantly problematical for him. Again, we followed the evidence-based treatment from day one, and the referral was timely and appropriate by following the referral pathway. Sorry, I've gone back instead of forward. I do apologise. Hence, you can tell it's live. So we implemented continued cleansing and debridement. Nothing else deviated from the treatment other than we implemented the URGO Start Plus primary dressing. Again, from the evidence, we want to kickstart that wound healing process and re-energise the wound healing. And then tubular retention toe dressing. And as you can see here, from day 1 to complete healing, healed by week 4. And that for me, with that patient with those high risk factors, was fantastic. Improved quality of life, improved pain score. And, that's what we all aim for our patients, isn't it? We don't want to delay wound healing. So what was our recipe for success? It wasn't complicated. Evidence can be complicated, but it is so easily, like with NICE and like with other recommendations, that evidence is put into simple, clear assessment and treatment pathways. And that's all we did, okay? But it was that consistency that helped, that reducing that variation in care. And we use treatments that have been high level of evidence, high level of evidence, and implemented that, and you saw the results. We ensured that our pathways and our treatment plans align with national guidance, such as NICE and National Wound Care Strategy and other campaigns. And it's important we work together and share that and share the work together. And we robustly record the clinical outcomes, demonstrating consistency in care and returning our patients to healing. And giving that real-life evidence, if you capture data, it's meaningful because it can help you to support future service development. And you can do it. Sharing evidence and best practice in real life, as I've said, is important to me. Our patients deserve the best available treatment. And I feel privileged to have shared with you this evening our work, past and present, and our real life clinical experience from the implementation of those pathways with our patients. And I hope this evening has shown that clinical evidence, strong clinical evidence embedded into simple clinical pathways can be replicated across different organisations, different care settings. And I hope that we've given you the confidence and tools to support you now in replicating the positive clinical outcomes for your patients. So I challenge you to be a change maker and implement NICE guidance for your patients too. Thank you. And I'll go over to Alec now for the questions and answers.
Thank you, Joy. That was very good. And thank you all for your positive comments at home. We've got lots of questions, so we'll get cracking on with those. In terms of implementing a pathway, first and foremost, are we talking about implementing this specific pathway or creating a new one?
I don't believe in reinventing the wheel, Alec. But pathways, yes, they can be adapted to your local area. Mm-hmm. But if you've got a really effective treatment pathway that works, why would you change it? So it depends what the pathway is, but treatment pathways, if the treatments are working clinically, like we've shown here, why would you change it when it's based around the evidence? So I can see where you're coming from.
The reason I was asking is because we didn't touch necessarily on specifically how you created it, where you start from that, and some of the questions that I'm looking at that have come in are about how you actually start that process.
Can I be honest? How I started, I was reading the NICE guidance around the use of URGO Start Plus, and then I started to look at some of the research, and it's a lot of work, and I haven't got a lot of time to do that, and I'm sure the audience has certainly not got a lot of time to do that. And I thought, well, the evidence is there. So if the evidence is there, then let's just implement it into a pathway. So that evidence, let's give you an example. NICE, their evidence and their guidance isn't just from a committee, it's from a committee of reputable clinicians, some of them who I know, reputable with lots of knowledge and skills that guide these committees in saying this is recommended good evidence-based practice. So it isn't just a committee, it's clinicians, that I've worked with in the past that have got that evidence for us. So it's taking the evidence and sitting down and saying, well, how can we develop that pathway? I looked in other areas as well. There's other fantastic clinicians out there who've produced pathways and looked at what their pathways look like. But your pathway's got to reflect the evidence.
Yeah. And I think that just looking at some of the slides, which were quite powerful, in particular thinking about the one slide that you showed where you had 100% healing within 16 weeks. It's almost unheard of. So I mean, it's obviously you've obviously done something fairly special with the pathway. I'm going to get on to some of the questions that we've had from the audience. Do please keep them coming because we're going to be here for a little while longer. Keep them coming in. We'll try and get through to as many as we can. As I usually say, if we don't get through to all of them this evening, we'll create a document with all of the questions on that we'll put online, along with a copy of the presentation and a link, I think, with the pathway itself for people to actually access it and see exactly what it looks like in a bit more detail. So the first question that we've got, and you have to apologise, I'm looking down at my iPad,
it's okay.
my iPad here so that I can see them.
These questions are just coming in.
Yeah, absolutely. So they're just coming in. So the first question is, do you have any top tips for building a wound tracker?
Oh, I love these questions, especially when they're live. I think with the wound tracker, top tips that I would definitely think about is have clear objectives of what it is you need to capture, what you want to capture. It's got to be relevant, of course, and you've got to be able to use it. It's no good capturing data if you're not going to use it or it's not going to be useful. So a tip there would be to develop the wound tracker, you know, work with industry partners to help you. And I mean, I didn't have the time or facility to do that. Ask your colleagues, ask your team members to go through that track and say, what would you want to capture from your patients, you know, your involvement with your patient's care? Ask the patient, you know. It's more relevant to the clinicians, but I solely believe in involving the patient, and that's where the quality of life thing came in for our data capture as well. It was actually from talking to patients. And I would probably recommend also clear objectives. So, you know, do you want the clinical outcomes to improve your service or develop a service? Because it can. If you can show the good work you're doing, you reduce number of staff, but with more staff you could, you know, it can help to support that. Future funding for services, formulary inclusion, you know, if you're working, you can capture healing outcomes and it can assist with formulary inclusion. And I would say pilot it. Do a pilot. Okay. I didn't do that at first when I first started to use it. And we did make some tweaks along the way, but now the data capture we're using now, it's pilot it first.
Good. Yeah. I mean, the industry element is an interesting one. My background, as you know, for many years has been sort of, before I got into publishing and events, was wound care from an industry point of view. And industry, you know, they offer a lot of support for these sort of things, and they can move quickly. And if you've got an idea, actually asking industry if they can help you to develop something like a tool like this is just it's a really quick thing, because if you go to people within NHS organisations, it's obviously a much longer process finding the right person to be able to help you with those things. So my advice would be to follow Joy's advice and ask people.
And I think, Alex, it's about being transparent and clear, working with as you would be anyway. Yeah. And we went, you know, our organisation now is saying, you know, this data capture tool has been supported, you know, helped. But the data capture it captures data for all of our patients, no matter their wounds or whatever. You know, we don't have to, it's relevant to us and it's relevant for our patients in our clinical area. And,
Okay. So the next question, this is a good question. I think you showed some of the positive impacts that you've had since you've implemented the NICE guidelines, but this question is specifically, what do you think is the biggest positive impact you've had since implementing the NICE guidance?
I think obviously the clinical outcomes. Yeah. I mean, that goes without saying, isn't it? Is the clinical outcomes. But I would say the other positive things is its transferability, because sometimes you can implement some pathways, but they can't be used because they may be a little bit too complicated for other areas. So it's simplicity. But I would say definitely the clinical outcomes. And helped us to data capture, which we weren't doing. So, you know, if we're delivering a service and my organisation, the CCG or the trust say, right, okay, tissue viability, you have these members of staff, what's your outcomes? And we can't show that. I mean, it's like any business, you've got to be able to show what is the impact of your service. And if you need to expand that service or you require more staff, it gives you the information that you can say, actually, we do need additional staff or we do need additional funding. So I'd say those are the two. I mean, there's lots of positives, but definitely the clinical outcomes for the patients, but also is helping us to capture that really important data.
But that's also an interesting one, because if you can prove that you're saving money by having better clinical outcomes, then instead of the trust keeping keeping that money in the bank.
Yeah.
Then you can make arguments about things like, right, we want an extra nurse on the team, or we want an extra couple of nurses on the team because we're saving lots of money because we're healing patients quicker, we're getting better clinical outcomes. So actually, they go sort of hand in hand, I guess, don't they? So, yeah, I mean, they're really impressive. The last slide, slide that you showed with the toe that healed in 4 weeks with a patient with comorbidities
with high risk,
is pretty impressive.
Yeah.
Okay, so we've got loads more questions. What was the hardest part of implementing the NICE guidance in practice?
I suppose, what's the word? Convincing others.
Yeah.
Convincing others its importance, its significance, which you could say, oh, well, you've got the evidence. But
are you talking about others in general, or are you talking about higher-ups to get the pathway going, or the people
from higher up in the organisation through to some clinicians on the ground?
Yeah.
And that's because we're humans, you know, we all have different, you know, so that was a challenge. It was the hardest part, but actually, once, you know, we explained and talked about the pathways, what it could, how it could influence practice, clinicians join that journey. You know, you'll always get some little pockets of resistance, but again, it's having that, how can it improve? And that's, so I would say one of challenges about what is it we're trying to do, but just articulate that well and show it, and yeah. But I think that goes with anything we try and implement that's different. Or,
yeah, I mean, as humans, we're often reluctant to change, aren't we? So it's, you know,
and I think sometimes we have to show that positive outcome first before, you know, other teams or other areas say, actually, we'll do that. You know?
But that's why you're here tonight, to show the audience at home what you've managed to implement.
Giving people the confidence, isn't it? The confidence and the evidence, and sharing with them simple tools that they can use or adapt. And that's what it's about, supporting all of us. We're all out there trying our best for our patients, aren't we?
Absolutely. So the next question is about implementation again. So this is, did you face the same challenges in each organisation where you implemented the NICE guidance?
About acceptance and uptake, yes, slightly. In my new organisation, what was different is, in the previous organisation, it was around a clinic setting more so, whereas this, in the new organisation, it's everywhere, implementing it across a range of settings, which is what I've talked about tonight, you know, so like care homes, nursing homes, practice nurses, so where there's a mixture of different knowledge and skills. So that was different this time. But again, transferable, simple, and the staff are amazing. They're embracing it, yeah.
And the Isle of Wight's a nice place as well.
It's a lovely place.
Yes.
I'm very biased.
Well, I'll come and join you there one day, and you can show me around. So the next question, could you tell us a bit more about the quality of life tool that you used?
So the quality of life tool, in my previous organisation, it's what I looked at with my colleagues. Now, that quality of life tool has been changed since, because again, it's like everything, you adapt and you use it and then you think, no, that's not quite right. So the new quality of life tool has been updated. I'm due to publish it, and I'm happy to share it with anybody once it's been published, because we have made some changes to it. What it consists of is a series of questions. So you're my patient. I have a series of questions about how the wound may or your skin condition impact on your life. So I might say, does it stop you from leaving the home? And we score. And from the score, the higher the score, so we have a total then out of the questions. So if, say, the score out of 70 was 65, then I know that is impacting negatively on your quality of life. But what the questions also lead to, it's not just a question and a score. It then says, well, if this is affecting Alec and how he leaves the house, what can we do about it? Yeah. It's not just a score. It's like, okay, what are we going to do between us? How are we going to improve that for Alec? So if it's about the odour, let's improve the odour. So you're setting joint objectives with your patients and opening up that dialogue. So I just think there are other quality of life tools out there, and I will say some very good examples of quality of life tools, but I think we should start measuring that and saying, you know, we can make a difference for our patients. you know.
Yeah, and I think for anything that we're mentioning with regard to tools and pathways and things, it's just to reiterate that we'll get links to these and put them onto the website so that you can have access to them, so that you can take a look at them yourselves. We've got another question in from Lisa. This is, and this is, I think, a fairly common thing that I hear about, and certainly something that you'll come across. This is, we have a limited formulary to choose from, and those who can prescribe are discouraged from doing so after initial 2 weeks supply. Do you have any advice?
Oh, what a really good question. Ooh, I need a glass of wine after that one. No, this is a problem. This is a problem. It's about two elements to that question, is that you're restricted by your formulary.
Yeah.
So if you see the evidence, like the evidence around the URGO Start Plus range, but you can't use it, you know, because it's not available on your formulary. Or you can prescribe off formulary, but you can only prescribe for 2 weeks. I think, again, for Lisa, it's saying, you know, showing the outcomes, you know, and it is hard and it is frustrating, but challenging. Challenge is a positive thing. It doesn't have to be negative, and saying, look, we've got this evidence is freely available. This isn't just come from me. This has come from a committee of experts who've said this is the evidence. We've got research evidence, and this can improve this for our patients. And it's hard work. It can be hard work. But that's the only way you're going to make changes in your organisation, is by putting the evidence to them and saying, you know what, we're not following evidence. We're not following best practice here. And if you can use whatever you've used off formulary and show, that's where your data capture comes in.
Yeah.
Look at the difference this made just in 2 weeks. What's it going to mean in another 2 weeks? And can we include this in the formulary? Can we even undertake your own local evaluations and show then, because you've got your own live data to share as well?
Yeah, brilliant. I hope that answers your question, Lisa. We've got a final question. For those of you watching at home, as we said earlier, we're not doing this remotely, because we're actually at the annual Wound Care Today conference today. So we've been doing presentations and various workshops. I say we, you have. I've been in meetings with various people all day, but you've been on your feet and doing lots and lots of stuff all day. So it's been a very, very long day. So I do genuinely appreciate your commitment to providing this content. The final question before we let everybody go and enjoy a glass of wine, which I'm sure we will go and do, is I noticed you had good clinical outcomes despite the wounds being different. Does the approach work for all wounds? Yeah.
So again, that's a really good question, because when we started to capture the data, you know, we didn't just use the pathway for diabetic foot ulcers, venous leg ulcers, or whatever. We used it on an array of different wounds, you know, from pressure ulcers to acute wounds. You know, we had some post-surgical wounds that were slow to heal, and still had the fantastic outcomes. So what it's trying to show is that standardised care treatment, can be used across an array of different types of wounds. And to me, that's how it should be.
Yeah, I agree. Well, I think that was a lovely question to end on. I'd just like to say that tonight's presentation has been a slightly different style of presentation, because we usually focus on one sort of treatment, whether it's leg ulcers or pressure ulcers or another type of wound, and we look at sort of how you specifically treat that wound. But today it's been more about how you can actually, well, it's clearly how you can implement a pathway to actually, to just echo that final question, how you can implement a pathway to treat all types of wounds. So it's really, really interesting. So, Joy, thank you so much for your time.
No, you're welcome.
To everybody at URGO, thank you very much for supporting this event, and thank you for being here today at Wound Care Today. There should be some links on your screen at the moment for how you can find more information on URGO Start Plus. We'll put a link to the pathway along with anything else that we've mentioned that we have documents to, the NICE guidance and things, alongside the presentation, which will be available on our website from tomorrow afternoon. Can I just thank all of the team at Mole and all of my team at Wound Care People for the work they've put in for tonight as well. And again, for all you people watching at home, thank you very much for joining us. We'll be back soon with another Facebook Live. And have a good evening. And for all you mothers out there, happy Mother's Day for yesterday. We were travelling to Milton Keynes, so we didn't spend it, so we'll be doing that later. Thank you very much. Have a good evening. Good night.
Good night.